Good evening. Welcome to acetabular fractures, ABCs, Ts, and ACPHTs. So tonight, we're going to talk about a group of acetabular fractures which are closely related, which have some slight variations, and we'll explore those a little bit more tonight. Tonight, we're joined by, I'm George Russell. I'm currently at the University of Pittsburgh, Chief of Orthopedic Trauma, joined by the well-dressed gentleman, Milton Little from Los Angeles, and Dave Forsch from New York City. So tonight, what our plan will be, we'll get through this. So just a sort of content validation statement. AO is an independent nonprofit surgical specialty society dedicated to improve the care of patients. AO does not endorse or promote the use of any product or service or commit commercial entities, and equipment used in this course is for demonstration and teaching purposes only. The webinar will focus on 3 closely related acetabular fractures, and experienced acetabular fracture surgeons will demonstrate how they evaluate radiographs, CT scans, and incorporate that information into a treatment plan. The treatment plans will be discussed as well as demonstrated. At the end of this presentation, you should be able to understand pertinent anatomical and radiographic anatomy, and discuss the basic fixation strategies for stabilizing ABCs, APHTs, and T-type acetabular fractures. This is the run of the evening. We'll have 3 cases which our faculty members will work through, and if we have additional time, we will have an additional bonus case for us to work through. Just a couple of introductions. No acetabular fracture course could be adequately described or discussed without reference to the Purple Book or the book by Letournel. Everyone should certainly have access to that as they consider a career in acetabular fracture surgery. Today, we'll be talking about 3 types, straightforward drawn on these models: complement of chip route, the associated both column, anterior column, posterior hemitransverse, and then the T-type. Now, it should be noted that the fracture patterns demonstrated today are not necessarily clear. A lot of them are confusing. And the reason we put those in there is to actually show the real world of how these acetabular fractures are presented to you in your practice. So with that, I'll introduce Dr. Forsch, who will start talking about this fracture pattern.
All right, thanks, Dr. Russell. Appreciate it. Glad to be here with you guys. So this was a patient that was actually transferred to our institution. She is an 81-year-old female that fell. She got clipped crossing the street here in New York City, and she presents with this AP image in the trauma bay. This is an isolated injury, and the thing that was initially noteworthy was the dislocation or the subluxation of her femoral head. And so when I am reviewing this with the residents and we're going through fracture rounds, we always like to reference the radiographic lines of Letournel that we all should be very familiar with from the acetabular Bible that Dr. Russell showed you, the Purple Book. So the first thing that kind of we look at is disruption of the ilioischial line here, which we know is representative of the posterior column. So she significantly has displaced that, as well as a violation of the iliopectineal line, which we know is representative of the anterior column. Yeah, thanks, Dr. Russell. You have control, so you can kind of navigate the cursor as we're kind of chatting through this. And then there looks like there's a high disruption both of the ilioischial-Kohler's line and also the iliopectineal line, but it looks like there is possibly a dual disruption in the iliopectineal line. And that, it can be significant as far as diagnosis for this pattern just simply off of this one AP image. Looking at the sourceal, you can see that there's some disruption, particularly medially. And from this image, if I were to surmise, it looks like there's some anterosuperior intrusion of the femoral head. And then the remainder of the sourceal laterally looks to be relatively intact. We talk about referencing the anterior wall and the posterior wall, but sometimes that can be a little difficult, certainly dependent on the penetrance of the image, the quality of the image. But you can get a sense at the anterior wall that there's possibly some disruption if you follow what we refer to as kind of the anterior acetabular obturator line. Yeah, you can kind of see that there, George. And then the posterior wall looks relatively undisrupted, at least from what we can tell there, but it's a little difficult to tell. So, you know, I don't want to get too loquacious on the first case, but Milt, how are you following me so far? You agree with initially what we see here? You're muted.
I try to keep it muted while you are speaking, but the things that really stand out for me are, like you mentioned, the source seal and the medial portion of it, knowing that there's probably some component of impaction to it. The fact that, you know, that your ilioischial line is that far medially displaced, and the fact that you can see that, you know, that inferior ramus fracture, meaning that there's probably that fragment may be an independent thing. So the fact that I'm going to have to think about the way in which I get that back to where it's supposed to be are definitely the things that stand out for me, as well as how much displacement there is in the dome. And when you're a fellow, or at least when you have residents and once you get into practice, one thing that is really important, you know, you don't really like having these displaced fractures. You can reduce these to an extent, right? It may not hold completely, but the patient's going to feel a lot more comfortable if you give them just a tug on their leg. You're also going to get a lot better visualization on your imaging if you reduce this fracture just like you would reduce anything else. There's going to be some translation or transition back to where it was previously, but you know, often you can get them to a place of slightly more comfort, even without having them placed in traction.
So Dave, as you look at this, you've got to come up with a classification or at least eliminate some things. What can you eliminate just looking at this radiograph?
Well, I already know just based off of the disruption of the iliopectineal line and the ilioischial line that we are dealing with, you know, a bicolumnar involvement. So the fracture patterns that will violate both of those primary lines are going to be one, the transverse, right? The transverse posterior wall, which is commonly, you know, forgotten about when we're doing this evaluation on the AP pelvis. And then you have your ABCs, your associated both columns, your APHT, which could be either the column or the wall, but both of which can violate both lines. And then your last one is going to be, you said your APHT, your ABCs, your Ts, that will do that. So all of the other ones you can eliminate. So just based off of this one AP radiograph, you can eliminate 5 other acetabular fractures from your differential.
Good. Well, let's add to today's views so you can opine a bit more.
Yeah. The other thing before you go back to that I would reference that can be somewhat telling and helpful as far as understanding the displacement. If you go back, George, so you can see that the teardrop here, it doesn't look widened. It just looks like it's medialized. So that can be significant as far as what actually is broken and what the displacement is. So it could just simply be that there's involvement of the anterior column wall that involves the portion of the cotyloid fossa such that the whole teardrop is medialized. Or it could be simply that it's split, at which point you would see a significant displacement. So Milton brought up looking for, you know, a caudal exit through the ramus, which can be indicative of a certain fracture type, whereby you would see potentially the teardrop has been split, and then on one portion of the posterior column and another portion is on the anterior column. So the teardrop can be telling as well. And then so switching over to the Judet views, you can certainly appreciate the high exit there on the left of the posterior column, which we understand and kind of makes sense. And then you also can kind of see the fragmentation of the anterior wall, if you can note that out just right over the center portion of the femoral head. And then if you look at the image on the right, you certainly can see the dual disruption of the anterior column as it traverses the brim, caudally and then cranially. Right. And then from what we can tell here, the wall doesn't look to be involved. It's simply involvement of the anterior column, that dual disruption and that kind of anteromedialization, if you will, of the femoral head. So
that what I was going to say is you can see how far, that's the thing where you're going to be thinking about that impaction, the same thing like that is a lot of, you know, it's just a significant amount of displacement.
Yeah.
This looks really challenging. So We've eliminated a bunch of cases or a bunch of types of classifications of acetabular fractures. Let's move forward with CT scans. So this is a CT scan, which is on cycle. And what do you pick up on this? I'll slow it down a little bit.
Yeah. So it's a little unusual in the sense that I think it's coming from caudal to cranial, but generally we can,
Yep.
pick the same stuff. So you can certainly see here the involvement, and you can stop it right about there. So let's kind of go in a way that the participants are probably more used to looking at it. So you can see here the involvement of the anterior column, and that's relatively low. And I think we'll go through this in another case, but you can familiarize yourself with the bony landmarks about the pelvis, particularly in the axial plane. So you know that we're pretty caudal now in the low anterior column because that anterior prominence coming down was the AIIS, or the anterior inferior iliac spine. That's where the involvement of the anterior column comes. And then here, just adjacent the wall anteriorly, right about the level of the cotyloid fossa and the pectineal eminence, is where you start to see that second disruption of the anterior column. So again, for me, the way that I educate the residents is the bony prominences anteriorly is understanding where your ASIS is, the interspinous notch, the AIIS, so the inferior spine, and then the pectineal eminence and the psoas gutter as you work your way from cranial to caudal. Because that way, when you're looking at something like this, you know where you are in space as you come down more caudally. So you can see that posterior involvement now, the posterior column exiting out the back. So you can show that as well, George, if you have the cursor. And here, just at about the level of the sourceal, which is going to be, again, just caudal to the AIIS, you can see that the head is just subluxed away from the sourceal, which we know, right? So that anterior-superior migration. And then you can see that posterior exit point through the retroacetabulum, indicative of the posterior column exit for the hemitransverse component here, which is pretty moderately displaced.
Okay, very nice. Let's move forward in the interest of time.
Yeah. And then so the other thing you probably saw, and it was highlighted on the obturator oblique as well as on the caudal view, is that there is an ischio-ramus exit point. Here on the coronal, you can appreciate again the high exit point of the posterior column, and it doesn't look that there's any fragmentation of the quadrilateral plate. That's something that you commonly will see with this pattern, but in this particular patient, she doesn't seem to have that. So the quadrilateral plate seems to be intact entirely with the quadrilateral plate. So to one of the points that Milton brought up, as we work our way through the sourceal now, you can see here that there's some marginal impaction, and that's commonly present. And the thing that you need to be mindful of and try and understand pathoanatomically is that marginal impaction just part of the anterior column, or is that truly a separate fragment? The other thing is, and we see this often because at least in my institution, we get a lot of referrals for even acetabular fractures. And there are those that may be waiting 24 hours, 36 hours for transfer, and they may be subluxed like this and won't be in traction. So to the point that Dr. Little brought up, it's really important to try and get the femoral head off of any fracture edges that will potentially cause some incursion, if you will, into the femoral head, because it only takes a short amount of time before they're just kind of rolling around in bed, turning, and then all of a sudden the femoral head becomes worn away or eburnated because it's just been resting on that fragment right there.
Yeah, and it's really dependent on when these patients get here. So the sooner, if you're in if you know people who are in smaller hospitals, or you get this phone call, you can tell them, hey, just give this lady a push, or give this lady or that person a pull to get and take an x-ray just to see if you've reduced this fracture, so that they are a little more comfortable, but also so that you can avoid more injury to the cartilage, especially depending on the timing of when they're going to get to you.
Yeah, and it's a gentle move. It's not just kind of yanking on the leg. Sometimes there's a moment of lateral traction as well to try and disengage. So it's distal and lateral traction. And then just moving along to the sagittal, you kind of can appreciate some of the marginal impaction. Again, the sagittal is not super helpful for me. Sometimes it's helpful to know where the retroacetabular point is in relation to the exit about the posterior column, more cranial, more caudal, and then some of the marginal impaction. But by the time I'm looking at the sagittal 2D reconstruction, I have a good sense of the fracture pattern. But you certainly can see here some of the fragmentation of the anterior column, and then the displacement about the posterior column and the cranial exit point.
Very nice. So let's move forward to a 3D CT scan. So what is the use of a 3D CT scan in your practice?
So for me, it just kind of corroborates what I've already gleaned from the radiographs and from the 2D CT scan. It's kind of the cherry on top. You technically should have a good understanding of the fracture pattern before you even get here. So whenever I'm in fracture rounds and the residents go to a 3D model, whether it be the pelvis or periarticular fracture, whatever, I say, whoa, you got to go back. So you have to be able to understand that what you're dealing with, because there are certain things that you can't pick up if you go straight to the 3D, particularly marginal impaction.
Very
And
nice.
it'll wash out, it definitely will wash out some of those fracture fragments that, you think, things that you think are incomplete that are actually complete.
Totally.
So, you get inside thinking you'd be working in one way and you're not, right? So if you look at that posterior wall component or that posterior column component, mainly the posterior wall component, you can see that that's probably more complete than it looks on that image.
Yep.
Very nice. So now we have a diagnostic dilemma. What are you going to call this, Dr. Forsch?
Yeah, so given everything that we know now, I would hang my hat on an anterior posterior hemitransverse, with the anterior moiety being more of a wall. So the common, the transition between that and the other fracture pattern would be, okay, well, is this a T, right? So there's a transverse component to it, and then there's a caudal exit through the obturator foramen. Well, doesn't that make it a T? So those are the two patterns I think that can be commonly misconstrued, if you will. So we know it's not a transverse posterior wall. We know it's not a pure transverse. We didn't comment, but you can see at this point there isn't a cranial exit through the iliac wing, which would be associated with an ABC, whether it be a high, intermediate, or low column, or anterior column fracture, but you don't see that. So that leaves us just with a T and an APHT, or anterior posterior hemitransverse.
Yeah.
So, the subsequent question is, well, how do you tell? What's the difference? So you see the dual disruption of the anterior column here, just about the anterior wall pubic root, and then the low anterior column, which is just at and slightly caudal to the level of the AIIS. So it's a pretty low column exit cranially, but it does have that so-called kind of quadrangular dual disruption of the anterior column. And then you oftentimes will see an anterior medialization or anterior superior position or posture of the femoral head as it tries to escape through the anterior column. I oftentimes kind of call it an Olay fracture, if you will. So the femoral head kind of wants to, push and punch right through the brim, through the anterior column and the posterior column. It kind of opens almost like a saloon door, almost like an Olay, if you will, if you're into like the Matador thing, right? So the bull is trying to rush right through the drape. And that's what the femoral head wants to do. That's classically what you will see in an anterior posterior hemitransverse. Most of the time with the T's, you'll see significant displacement of the posterior column, which this patient indeed does have, but the femoral head generally wants to migrate out the back via that posterior column disruption. So we don't generally see that here. They both can have an exit point through the obturator foramen. Classically, what you'll see is that the anterior posterior hemitransverse moiety will have a more anterior exit point through the ramus. This one doesn't, but again, just speaking generally, that's what you commonly will see. And oftentimes the posterior exit point will be incomplete or non-displaced, which is what throws this one a little bit, because in this variant, the posterior column does seem to be very displaced and it exits more cranial than what you otherwise normally see with an APHT. So that's where I think some of the, the gray area can be. But even to Professor Letonel's point, a lot of these are transitional patterns and don't necessarily cleanly fit sometimes into a clean description. But in my diagnosis, I called this and we treat it as an anterior posterior hemitransverse.
Good. I'm calling it a T. So what are you going to do?
So that's the beauty of this. So this is, for me, gets approached anteriorly. So I initially was trained to do all three windows of the ilioinguinal, and then kind of migrated to doing more of an AIP or stopper approach with the first window. But some of these low patterns you can get through purely just in intrapelvic window, which is what we decided to do here. You can see to the prior points made about what the benefit of putting them in traction is. So this is just a femoral distraction via a Shan's pen into the femoral neck. And so just by doing that, you can see restoration of the teardrop in its relation to the ilioischial line. you can see that now we have the femoral head situated under the source seal. And so that's a very powerful tool. And you can either do that manually or with a special table whereby you can hook it up to your pen.
Very
My
nice.
my move here, so the image on the left for me is kind of the crux of the case. So with two ball spike pushers and a disc, you can see that you can kind of close that door, if you will, and buttress down the anterior column as well as the posterior column. And if you have that nice axilla and that foundation, then you can keep the posterior column home just with the mechanism of buttressing in that vector. And so the one thing that we didn't note, this is kind of what's been described as a favorable obliquity, if you will, of the posterior column, in that the exit point is more cranial medially and more caudal laterally, such that if you push along the line of that vector for that second ball spike with the disc, if you just buttress it in that manner, that should bring the posterior column home. And so that's what we elected to do here. And the plate that we utilize here on the right is just a specialty plate that has a quadrilateral infrapectineal attachment to it that allows you to reproduce that same vector of lateralizing the posterior column into that well-reduced and buttressed anterior column. So now you have the axilla. And if you go to the next scan here, George, you can see that once you secure and buttress down through the parasymphyseal anterior aspect of the plate, it buttresses down the anterior column, and then now you can lateralize the plate and put a screw into the sciatic buttress, which really brings that posterior column reduction home. So the other thing to note here that I think Milton brought up, you have to be mindful of marginal impaction, and this is very common in this pattern. And so again, you either kind of get lucky, and you don't really know until you can reduce the anterior column if that marginal impaction is going to reduce. And sometimes you get lucky and you reduce the anterior column, and it's like, okay, great, now everything is concentric and that marginal impaction is addressed. But if it's not, then you have to find a way to address it. And so you can either do that one of two ways, either making a cortical window, or if the quadrilateral plate is comminuted, and then you can stick a freer or an osteotome. A curved osteotome is generally what I'll use and work through into localizing that marginally impacted articular segment. And so that's what's being demonstrated here. Classically, what you'll see if there is comminution about the quadrilateral plate is that the fracture line will be just slightly caudal to the brim, such that you can work through an area of comminution and localize any marginal impaction, reduce it, and then you can put screws across it. And if there's a big void, if it's significantly displaced, I generally like to use beta tricalcium phosphate putty and kind of tuck it in there. Some people like using allograft croutons or even an injectable, but whatever your rafting bone void filler of choice is can be helpful here. And if you go to the next slide, George, so I'm a big proponent of placing screws very, very close to the joint surface. So once you get everything restored and just rafting it, and you either you kind of swing and a miss, or you hit a bullseye, right? So in that case, if the marginally impacted segment does end up failing on you, the joint kind of wears away rather quickly if it's a swing and a miss, if you will. And then you can lose the joint pretty quickly. But even if it does subside a tad, they can tolerate a little bit of incongruity anteriorly. So I generally will put the screws very close to the joint and not worry about, oh, well, if it fails and, the femoral head abuts the screws. But generally, if you work through comminution about the brim or through the quadrilateral plate, you sometimes can see that posterior superior area of impaction, and you can bullseye it with a screw.
Very nice. Very nice. So here were our final x-rays.
Yep. And then so lastly, that screw is Letronel is a big advocate of that screw. It's so-called Letronel screw going down just adjacent to pectineal eminence and skirting down the cotyloid fossa into the posterior column. So that is generally what will link fixation into the posterior column, in addition to that lateralizing screw going through the column and into the buttress, which really keeps that posterior column home. Generally, if there's extension of the comminution into the posterior column or quadrilateral plate, then I'll use a different infrapectineal plate, which would extend a little bit more caudally. But for the more cranial exit points about the posterior column, this infrapectineal extension from this plate is more than sufficient, I found.
Very nice. Very nice fracture.
Yeah,
So
just one comment. The one thing I would say for me that you do have to be careful with this plate. It's stiff. It's a very stiff plate, so it can, sometimes it's helpful to have the reduction in place because and either wire it in place because sometimes it can kind of mal-reduce things a little bit. So just being thoughtful about that. And then the other thing is, if you need more posterior column fixation, sometimes those proximal screw holes in the plate, depending on where that plate sits, because of the quadrilateral plate, it may not sit lateral enough, or it may sit a little bit too lateral, or it may sit a little bit too medial, and may impact where you can put your drop down screws if you're putting them through the plate itself. So feel free to place drop downs that are outside of the plate, connecting the anterior column to the posterior column.
Very
That's a
nice. So
great point.
using the moderator's prerogative, this was a T-type, was a beautiful T-type approach anteriorly. Now, Dr. Little, this is the same type of fracture. It's a T-type, and it's a little bit different. Describe what's different in 2 minutes and tell me what you would do differently, if anything.
Yeah. So just the things that I look for on my, you want to look at the location or the area of most displacement, right? And so looking at this one, I'm looking at my anterior column on that middle view on my obturator oblique, and my anterior column is not as displaced as my posterior column, right? When you look at that first AP radiograph, you can see that just like the last one, there's a lot of internal rotation of that posterior segment, and you can see the dislocation or the subluxation of your femoral head, primarily following that posterior column, like Dr. Force mentioned. So that's the thing for me that tells me I'm going to go posterior for this. It's just a question of, am I going to be able to get my anterior column reduced enough? And that's the information I'm going to want for my CT scan.
Yeah, so in the interest of time, we're not going to go through all the images, but just highlighting the difference in T-type fractures. And this is, you can describe the fixation, which would be fairly typical.
So the other thing that, and for T-types, really to think about, make sure you're looking at your SI joints, both sides, because they do have a little bit of a high possibility of having the involvement of your SI joints. So that's something that can provide a little bit of instability. So looks like you were able to get the SI joint reduced, or not reduced, but you were able to get some compression using a screw. And then you got a reduction of your anterior column fixed with a partially threaded anterior column screw or a Ramus screw. And then you used both a column plate as well as a posterior wall plate, because there may have been a wall component to it, with the use of a spring plate, which is under both of those plates there.
Yeah, so very nice. So I think that the important point for the webinar is that T-types does not mean just one exposure, either anterior or posterior. Understanding where the greatest displacement is, and then also in the first case we talked about, there was a lot of comminution anteriorly, even though there was some debate about what kind of fracture it is. It's a T-type based on the moderator's prerogative. So in that example, we had to sort of go anteriorly. Next case, Dr. Little.
Yes. All right. So the next case, we're looking at our AP view, the things that stand out for me, where I'm looking and I'm seeing that there definitely is there's definitely involvement in my iliopectineal line. There is involvement in my ilioischial line, but it's not a lot of displacement there. And when I'm looking at this globally, I'm also paying attention to the fact that there's involvement of my right-sided parasymphyseal region, both with an inferior ramus fracture, probably a superior ramus fracture. You can see that there are parasymphyseal fractures there on the front of the left side as well. And then the other thing that stands out to me for this injury, looking in the back, even the posterior involvement doesn't look like it extends as proximal as it did on the other one, on the other side. I'm really going to be curious as to what's going on, whether there's anything else involved with the SI joint on the left side. And then the fact that it looks like the ischium or the ilium, there's definitely a fracture that extends from the AIIS to the ASIS. And then there's a dome fragment that's attached to the remainder of the iliac crest. And then you kind of have your stable fragment more posteriorly. And then from there, I'm going to go to my Judaes, and I'm going to look at my Judaes and things I'm going to look for on my Judaes on my obturator oblique. I want to see how displaced that anterior column fracture is. So you can see that there is, it looks like there's a little segmentation there or a separate fragment. And then when I look down near the parasymphyseal region, I know there's a separate fragment there. I know that it looks like it does include my inferior ramus. And then for me, I'm going back up and I want to study kind of what's involved with this ilium fracture, right? So, when I want to know what's involved with it, I know I'm going to be able to see it here. You see that intercalary segment, and the area where I'm probably going to get more understanding and more visualization of that is actually my iliac oblique, right? And so going to my iliac oblique, there you can see your ASIS and your AIIS all on one fragment. You can see that there's a huge piece of the dome, which is attached to that middle intercalary segment. And you can see that fracture, which extends all the way down. Then you can see the involvement of your posterior column, but your posterior column involvement is lower. And so thinking about that kind of helps me to understand what else is going on with this. And the only other thing I want to know if there's more, it looks like there's dome involved, or not dome involvement, but there's dome connected to that posterior segment that's proximal to your kind of where it exits out of that posterior column.
Very nice. So we'll just move forward to the axial scan.
Mm-hmm.
And it's going pretty quickly, but I'll just kind of go through it.
Yeah. So right here, following that, right, for me, I'm following that anterior column fracture, right? And there I see the segmentation of it. And right, that's your main anterior column fracture line. Posteriorly, I'm following the posterior aspect of that. And there you can see some dome involved on it. And then as you go lower, you see that the posterior wall component of it, which is attached proximally. If you go proximal for me for a second, you can see, I think that's all attached to that intercalary segment right there, right? So that big intercalary segment is attached to that posterior wall, but maybe there's a little kind of fracture line that extends there as well. And then as I come to the front, the same things we mentioned, both the parasymphyseal injuries, and then kind of the exit out of the inferior pubic ramus.
Nicely done. We'll just go to the next image. So for this, we have our coronal.
And so these same thing I want to look for. My coronals, I'm really thinking about impaction. You could say there's probably maybe a little segment of impaction just a couple of slides back. Right back a little bit further, or at least that may be a separate fragment that I'm going to have to think about when I get my reduction. And then, so those are kind of the things that stick out for me. And then kind of the segmental component of that, you see your posterior column fracture, which is low, as well as your posterior wall fragment.
Very nice. So we talked a little bit about sagittal scans. And so Dr. Forrest says it doesn't always help that much, but sometimes it does. So in this example, does it give you any good information?
Yes, it gives you that. So that's that fragment that I thought I was looking at medially, and there it is. It's impacted, and that tells you you're going to have to bring that down. And depending on what you do, right? So that if you bring everything down too early, you may not leave enough room for that piece to come down to its home where it's supposed to be. So it's something to think about.
So if we move forward to the 3D. And again, 3D is typically, as you both said, the last thing you do. So does a 3D, what does the 3D offer you in this example?
So it once again tells you, all right, there is a true posterior wall component. So we have to think about that. We can't forget about it. You do have, your segmental iliac wing. You know that there, and then you know that there is some displacement of the posterior column, but you know that it's intact with a component of the dome attached to it. Right?
Uh-huh.
Mhm.
Very nice. So let's talk about, in the interest of time, so what do you think? What was done?
Yeah, so playing, the orthopedic um, pathologist, where I'm looking back at things and trying to see what happened. Um, the things that stand out for me are, how am I going to, number one, bring my wing back together, manage those segmental components, and what order am I going to do that? I know that I don't want to lock up one side completely until I'm happy with my alignment, and so I know that so thinking about the right side, I know I'm going to go that a little bit later. So I know I have nice reads for my iliac wing, as well as my nice read for my ASIS. So I'm probably using some small pointed reduction clamp to bring those together. And then probably for me, placing provisional wires, holding them in position. As I do that, I'm then going to want to bring that posterior column over. So I will probably use a clamp. For me, for this case, I'm using all three windows of the ilioinguinal approach. I like my middle window because that's going to help me with that, the first portion, or that portion of displacement of my anterior column, and it's going to allow me to see that reduction. I also like my middle window because that's going to allow me to place a clamp there to bring my my posterior column over a little bit and grab my reduction. So I'm definitely going to be thinking about that. And so I think, for including all of that, but prior to doing that, I may be working through that through the intrapelvic approach to bring down that impaction, which you can see, it looks like it's been brought down nicely on your obturator oblique. And so probably locking up the wing once I get all my clamps in. So I have my intrapelvic clamp, I have my wing held in position. I am then placing my plate, and then placing this posterior column screw once I'm happy with my anterior column reduction and my impaction. And then I'm extending that anterior column plate over to the contralateral side, versus using a retrograde. You could use a retrograde Raymond screw for that as well, as another option for managing.
Yeah, absolutely. And then one component is that the wall
Yeah.
wasn't fixed.
Yeah.
So talk through that a little bit.
So, I think about the wall in terms of how much displacement there is on that wall, what it looks like on the CT scan. On the CT scan, the wall looks like there is not that significant displacement. I think you could, I think that one thing that Dave mentioned was using an intrapelvic screw that's going right above your area of impaction. And that's also a really great screw for finding your posterior, getting your posterior wall, depending on where you're placing it in the intrapelvic region. I think that, given the amount of soft tissue, or the location of that displacement, I think it's likely that there isn't that much disruption of the periosteum over that posterior wall. So I think you could avoid placing any fixation in it if you think you have it in place.
Very
I think
good.
one,
Very nice.
if I would add in, I totally agree with everything Milt said. The one thing that can be exploited with this particular fracture that I think proved to be a little bit, fortuitous for you, is that segmental nature of the iliac wing. So you essentially already had an ASIS osteotomy.
Yep.
So if you wanted to slip a clamp down to grab the posterior wall, tuck it away and put a screw. If you wanted to do some more brim work, even working through the same portal that would you almost would be afforded through the middle window, you could just work through that kind of ASIS, a double IS osteotomy that the patient gave you, and then that would be the last fragment that you could reduce home if you wanted to exploit that. So that's an option when you have that particular fracture pattern.
Very
I mean,
nice.
the one thing I would say, I like how you tensioned that, tensioning. One thing I think about is just the way you tensioned that AIIS or that segmental component in using that third tubular, right around that piece to then tension it in. I think the benefit of that over sometimes placing that a kind of low LC2 screw is that sometimes that LC2 screw can get in the way of your posterior column screws unless you're placing it just right or just aiming it just a little bit more posterior or a little bit more lateral rather than aiming it directly at your PSIS.
Very nice. Well, thank you, gentlemen. That was a great commentary. We have one more case for tonight. Dr. Force, you're up.
Yeah, so this one I think was a younger patient. Figure what his mechanism was, but he presented. So with the same kind of intrusion here, you can see he has some dye in his bladder, so he has a pretty big hematoma that's pushing everything to the contralateral hemipelvis. So it's a pretty significant injury in that regard. And again, similarly, looking at the radiographic lines, I think we all are familiar with now. So he has a disruption of both the iliopectineal, ilioischial line. He doesn't look to have, if you look out into the ilium, he does have some fragmentation that's extending out into the cranial iliac wing, which we'll get a better sense of when we turn him for his due days. But pretty significant disruption of both the iliopectineal, ilioischial lines. There looks to be some violation of the sourcile as well. And the teardrop is pretty blown out as well, which is significant to the intrusion. So again, if you flip them over and look at the obturator oblique view, you can appreciate the comminution and segmental nature of the anterior column exit point. And then you don't see a posterior wall significant fracture, but you get a sense of, can you see that right there? Show them a little bit of this, what's a spur sign would potentially look like here. So if you look at right about there, just above the posterior wall, there's a little fleck of the intact ilium, just cranial to where the cursor is there, just slightly cranial and lateral. And so when I see something like right about there, so that wants to be a significant spur sign, and that can be very, very subtle, but just that alone can tilt my hat to saying, okay, well, I know what this is. And then if you look on the iliac oblique view to the right side of the screen, you can see the blowout there of the posterior column and disruption, and then some of the fracture lines that are extending out into the cranial iliac wing.
Very nice. So in the interest of time, we'll just kind of scoot along a bit.
Right, so this is a better one coming from cranial to caudal. You can see the intact ilium. You can see it started the fragmentation in that cranial anterior column of what we got a sense of on the iliac oblique view. And then as you extend down, if you follow the intact ilium, you see it starts to peter out. And right about here, there is a little bit of marginal impaction of the posterior, right there. You can see that that's disassociated. So if you see the posterior acetabulum there, the articular cartilage is dissociated from the intact ilium. And it's just as subtle as that. And that lateral caudal break that you see there is what's representative of the spur sign. So just that small nuanced detail, you can get a sense that there's no articular portion that's attached to that intact ilium. And then as you work your way caudally, you can see some of the fragmentation of the caudal anterior column and it exiting out through the inferior ramus there.
Very nice, Dr. Force. And then so we'll just quickly look at the 3D.
Right. So again, so this is almost we know what it is. So this is an associated both column fracture, just simply given what we just reviewed on the axial. But if you look at the 3D, it almost is behaving like an APHT in that the iliac wing fragments, you can see that there's a lot of incomplete fracture lines that are there. It's not significantly displaced such that you would say, hey, well, I think I need to start more cranial in the ilium, reconstruct that similar to Dr. Russell's last case. You actually can probably approach this like we could the first case, the T or the APHT, and just deal with the more caudal brim in the posterior column, and then deal with the cranial iliac wing last. So it's by diagnosis and pathoanatomy, from what we can see, it's an ABC, but it's almost behaving like an APHT as far as how you would address it. So that
Yes.
was kind of my thought process here. And so similarly, what the patient needs initially, what we start with,
You want to
yeah,
There
you
you
want to
go.
do you want to do the models first?
yeah,
Yep.
model.
Go ahead and stop your share for a second.
Yep.
Right now, let's see. George is highlighted. Is everybody seeing me? Or
Yes.
hard to say?
Yes, we see you.
Perfect. So here's our model. Kind of same thing. We have that. This is kind of what Forrest was talking about. While it looks like this is intact, there's a component of impaction on the backside that really turns this into a, into an ABC. I think the one thing to keep in mind, most of the time you have a true big fragment kind of here, which would be your true spur sign back here, showing us, on some kind of more standard rather than being this kind of transition, right? So, we're dealing with a group of fractures that are all very similar, and one little subtle fracture line automatically changes the classification. And then you can see this one kind of exits a little bit higher, so more so in between this anterior and superior iliac spines. For me, when I'm getting that reduction, like we talked about before, I'm working through my intrapelvic or AIP, my intrapelvic window, and kind of this is the clamp that I'm placing, and that's right on that quadrilateral plate fragment as well as on the pectineal eminence, and that's where I can get a lot of compression and closing down that fracture, bringing down my anterior column. And so I'm placing that, and as soon as I place this clamp, I can then either wire things to hold it in place, or if I can move my clamp more medial, I can then, if I'm planning on some kind of modular fixation, I can place my first plate on the outside or just inside to it or medial to it, so that it's not blocking my way. So that's one of the ways in which I'd use that clamp. And then in terms of what we had mentioned previously, like this case, there is a posterior wall component. So through my lateral window, I can use a clamp by making a small rent on the external oblique fascia, getting this clamp down on that posterior segment. And this is the smaller version of it. But then once again, putting my other piece once again on that quadrilateral plate to hold my posterior column in place, or my posterior wall in place, prior to kind of getting any fixation or any plate fixation.
Thank you, Dr. Little. That was very nice. And so then we'll just look at what happened. So if we go through sort of very similar fracture reduction. Yes, Dr. Forsch?
Yeah, so utilizing kind of some of the reduction tactics that Milton just told you about. Once you get the columns reduced, then it's just a matter of kind of securing your plate. And this is, the same plate. So to Dr. Little's point, sometimes this plate that you see can be rather stiff, and there are different iterations of it. Kind of off label, if you will. One of the things you can do is kind of cut one of the limbs of the plate. That gives it actually a lot more malleability, but nonetheless, the concepts still remain the same. So you can see here about this pattern. Again, we know it's an ABC, but we approached it almost like an APHT in that we did our more caudal brim work and periarticular reduction, and then secured some of those more minimally displaced iliac wing fractures that we could simply use with traversing screws. The same screw fixation into the posterior column that I showed you, kind of the so-called Letournel screw, that's just juxta-articular and aiming down into the posterior column, and then standard posterior column screw fixation through the plate itself, linking both of the columns there.
Very
Dr.
nice.
Force, one of the things that one of the questions were mentioned, how do you put that Letournel screw in through the anterior through your AIP approach?
Yeah, so I think I responded privately, I think, to that gentleman with that participant. But for folks who were wondering, if you do a good AIP and dissect all the way along the brim, your entire anterior column is exposed. And actually placing that screw on the view that you see here on the obturator oblique view becomes rather easy. Your trajectory, your start site is juxta-articular, which you can see very readily through the AIP. So it's actually not a very difficult screw to place. You know, if the screw that you can't place into the posterior column through your AIP or some of the more cranial screws going into the posterior column because you simply can't get that trajectory. So that would necessitate making a lateral window exposure to put those screws in either through the plate or just lateral to the plate. And in the situations where we talked about the first case where you kind of have that obliquity of the posterior column, where it's more horizontally oriented, or even what we call sometimes a reversal obliquity orientation of the posterior column, where it's more caudal medially and cranial laterally, where you can't push and lateralize the posterior column because it's going to displace the ischium out laterally. For those scenarios, for that fracture pattern, I'll make a separate lateral window because I really want to get screws going down through the lateral window deep into the column.
Very nice. We have one question. Question that we have is can you give any tips for maximizing the first window? I imagine it's the lateral window exposure beyond ASIS osteotomy or ligament peel. How do you make it easy working back by the SI joint?
Yeah, so that can be very difficult sometimes. You know, we talk about more so relaxing the middle window with flexion or extension of the hip. You can gain a little bit more kind of suppleness, if you will, by flexing the hip up. I actually have kind of graduated into using an osteotomy a lot more just because it's pretty low morbidity and it really opens things up. But some gentle hip flexion also can be helpful for that. But what I find is an osteotomy, if I'm really doing anything around the sacroiliac joint or need to do more brim work and even working down into the juxta-articular anterior column.
There are a couple of other things you can do. You can, if you're not doing a full ilioinguinal, you can partially incise through the inguinal ligament. And then down to the lateral femoral cutaneous nerve. And then to supplement that, even you can take off the anterior portion of the inguinal ligament, which gives you wide exposure into the brim, and you can elevate the iliopsoas muscle nicely off the false pelvis, which gives you a lot more exposure.
And that's kind of the fact that's generally my standard lateral window, right? So I will do the peel most of the time because I like to get as distal as I can. We get this collection of a lot of those low exiting as well as a collection of the ones that exit normally, but there's a bunch of those low exiting ones where that exposure of that distal aspect of your lateral window is very helpful. I'm still a big fan of using a middle window in my in a true ilioinguinal. One of the reasons is, you know, I do want to make sure I'm happy with my posterior column fixation, especially when that's your primary area of displacement. You know, getting as many drop downs as I can into that segment to protect it. And that usually I can do those, you know, I'm going to be doing all of those for my lateral window.
So in the interest of time, we're about to wrap up, but Dr. Forsh, I noticed you put inlet and outlet views for your acetabular fractures. Does that offer you any additional information that you can share in 30 seconds?
Yeah, I do. Simply if you're doing any infrapectineal buttressing. So, you know, Milton brought it up, I think of one of the other cases, particularly if you're using a plate for quadrilateral buttressing. Not every fracture needs a quadrilateral buttress, but if you're going to put an infrapectineal plate, you want to make sure that it's well opposed, particularly in the posterior column, and it's adequately contoured. So that's why for me, every time I do a pelvis or an acetabulum and I'm using infrapectineal fixation, I always get 5 views of the pelvis.
Excellent.
One other question, one other just comment. You know, I know we had mentioned talking about it, just post-operative CT scans. Are you guys getting them on your acetabulums every time, sometimes, rarely?
So I don't routinely get it. I kind of stopped, but the times that I do routinely get it is if I'm doing a sequential approach. So if I have, a T or an ABC with a segmental posterior column or a wall where I need to go to the back after the front, then before I do that, I will get a CT scan to make sure that everything is righteous and that I haven't blocked out my capacity to reduce the other column.
Yes, I get them every time. I think it's a great learning tool. It certainly highlights um, uh, like articular reduction is much better than plain films, and it really is a great tool to help you understand what is going on with it. Balances what you think would happen and what actually did happen
Definitely.
in the injury. So we
Very
are
humbling too, right?
yes,
Yep.
very humbling. Yes. So if you look at people who write about these types of fractures, and you look at them who write about CT scanning, you'll notice a distinct drop off in the amount of anatomical and imperfect reductions when you start looking closely at the CT scans. And I think it's a very valuable tool. I think now you can avoid a lot of radiation and do the O-arm if you have access to that. But the radiation is not insignificant, but especially in the early part of your career, it's very illustrative about how you're able to stabilize these fractures. So in summary, I'd like to thank everybody for participating. Just a couple of highlights. One, we talked a lot about the Purple Book. Reference that is an essential book, almost a Bible, if you will, for acetabular fractures. And everyone I would suggest should have that if they're going to do this in any significant degree. We worked a lot on preoperative classification. We showed some radiographs that were oftentimes very transitional and open to interpretation, but highlighted the very basics of sort of the operative positions and the operative exposures. Dr. Little did a very nice job, albeit quickly, looking at some of the clamp applications, and Dr. Forsch as well showed some very good cases with intraoperative fluoroscopy views to help us understand better. And then to follow up with Dr. Little's question about postoperative evaluation, certainly plain films. Dr. Forrest noted that he also likes inlet and outlet films, which I also recommend, and then the postoperative CT scans. Just to follow up what's coming up, there is an AO webinar coming up on the February 21st regarding geriatric hip fractures, and again, another one on April the 10th looking at emergency hindfoot injuries. So at this time, I'd like to thank the participants as well as the faculty members for their participation tonight. I'll hang on for a little bit to answer the few remaining questions, and I'm sure we have, in the last 2 minutes, we can answer a couple of questions. The one question I have here at faculty is the postoperative CT scans can be a double-edged sword. Do you find yourself ever having to go back to redirect shortened screws if you find that they are long or misplaced?
I'd be lying if I said I haven't done that. So the answer is yes. There's a learning curve, and if you read the Purple Bible, Dr. Professor Letournel, mentioned, and he speaks to the learning curve, and I think part of that is, getting CT scans. I think we all do it early. Maybe I should do it more, but like I told you, I think the times that I do it, I have my specific protocols. But yeah, there have been times where I've had to take people back. Yeah.
And I think that, but I think what Dave, you're not mentioning is, I'm not taking somebody back for a screw that's 3 millimeters long, right? Where
Yeah.
you're taking somebody back if you're placing a drop down screw that now is that you thought was just outside and was right on the border, or looks like it may be intra-articular. You're taking somebody back for a, you think you have that posterior wall reduction, but it's not completely reduced. Or right, so there are reasons you're taking them back. It's not just 0.1 millimeter of displacement of your dome.
Yeah, it's not for radiographic.
So I don't think it's a double-edged sword. I think it's giving you the information you need to know, and it's up to your clinical judgment to make sure you're making the right decision as to what's the safest and best outcome for the patient. And then the other question was how you reattach the ileoing. So you're going to have a portion that's proximally, that's still intact. You're going to have a portion that is intact along the external oblique fascia. So that's where you're repairing it to.
Well, yeah, and I also think that Letournel does mention at some point in his book that you can release the entire inguinal ligament.
Mm-hmm.
And that gains you a lot of exposure. And then just as Dr. Little described, you can repair it back to the external oblique fascia. But the technique I described is not doing a full ilioinguinal. It's just incising the inguinal ligament through and through to the lateral femoral cutaneous nerve or beyond. Certainly don't want to interfere with the vessels, but that will give you an additional 3-4 centimeters, and then it helps you relax the iliopsoas and gain access to the brim more easily and the anterior SI joint.
Yep.
With that, I would like to thank everybody again. We appreciate your comments and participating tonight. Thank you to my faculty member, and we look forward to seeing you at the next AO webinar. Have a great night.
Thank you.